Here I am presenting certain neuro-ophthalmic signs in certain neuro-ophthalmological diseases such as third nerve palsy, Mobius syndrome, or ocular myasthenia gravis. In these cases and other neuro-ophthalmic diseases, identification of certain neuro-ophthalmological signs, they can be very useful for an ophthalmologist so that their time-consuming investigations and imagings can be prevented, and an ophthalmologist can establish a certain diagnosis in neuro-ophthalmological disorders. It will be very useful for the patient and for the ophthalmologist so that he can get to a particular diagnosis. I am presenting a case of Mobius syndrome in a child which shows the adduction. There is esotropia and abduction is deficient bilaterally because it is a bilateral condition. So now I am just demonstrating, just see the movements. Now you can see here I am showing you up movement with my finger going up. So up movement is intact. Now you can see this video is showing now the down movements, able to downward move the eye. Now you can see the abduction. Just see the left eye, it is abducting. Right eye was not abducting. Again the left eye is not abducting. You can see once again abduction. Just see, not able to abduct beyond midline is her right eye. Now the left eye not even to move beyond midline. So you can see now over here the facial movements, not able to grimace. So seventh nerve, this whole shows seventh nerve, not able to grimace again this side. Now I am asking the patient to laugh. You can see even not able to laugh. So facial expressionless, facial movements are absent. Just see, not able to laugh. Now usually in these patients Bell's phenomena is absent, but here you can see the patient is able to, the Bell's, in fact the Bell's phenomena is there. So in these patients the Bell's phenomena is usually absent, leading to exposure keratopathy while sleeping. This is a case of Mobius syndrome, which is having bilateral, this is a facial diplegia in fact, primarily affecting bilateral 6th and 7th cranial nerve. This rare neurological disorder present in infancy as large angle esotropia with the eyes fixed in adduction. The abduction is very poor. Even there is no abduction saccadic eye movements. The medial rectus muscle is virtually always tight and fibrotic. The bilateral 7th nerve palsy leaves the patient in a practical expressionless phase. As you have seen in this video, patient is not able to frown, suck, grimace. So expressionless phase. Other cranial nerves which are affected in this are 5th and 8th, leading to deafness. There are limbs and chest malformations which have also been described, and usually these patients do well with bilateral medial rectus recession. Now this is the second case which I am showing to you. He is a middle-aged man. As you can see, he is having right eye ptosis. He is having complete third nerve palsy. In this over here it is showing third nerve palsy. So when a middle-aged patient having hypertension or diabetes mellitus presents with third nerve palsy, it becomes crucial to exclude other oculomotor nerve palsies to prevent unnecessary imaging. Third nerve palsy in this age group without other neurological signs and other ocular nerve palsy is usually due to ischemia due to involvement of vasa nervorum. So this is a patient, a photograph showing third nerve palsy, complete ptosis. Now here I am trying to show the movement of superior oblique, that is in abducted position. The primary action of superior oblique is intorsion. So third nerve is gone, eye is abducted. Now you can see this is downward movement in abducted position showing intorsion of the right eye. You can see left eye is moving downward, down and in, and right eye. Over here you can see the intorsion movement of the right eye. So this shows that the fourth nerve is intact because the action of fourth nerve is intact. The other movements, abduction, adduction, upward movement, down, this is the downward movement, and now you can see the upward movement. So this is a third nerve palsy. The other movements are defective. As the ocular nerves are densely packed at orbital apex and they are closely associated in cavernous sinus, so demonstration of normal functioning other ocular nerves prevents unnecessary imaging, and these patients can be followed up without any intervention for spontaneous recovery. This is the third patient which I am presenting to you. This is a ocular myasthenia gravis patient. Myasthenia gravis is a chronic progressive disease characterized by weakness and abnormal fatigability of the striated muscles. It is of unknown etiology, but it is possibly due to a defect in the transmission of the nerve impulse at the myoneural junction. This disease is of importance to ophthalmologists because the manifestations are often initially ocular in nature and they may be the only sign of the disease. Osherman has classified the myasthenia into 5 groups, and the group 1 is ocular myasthenia. This is a localized form of disease limited to the eyes and is characterized by ptosis and diplopia. The ultimate prognosis is excellent and approximately 20% of the patients have this form of the disease in the myasthenia gravis group. So this is a case of ocular myasthenia. As you can see, ptosis left eye, ptosis both eye. There you can see this is the right gaze movement which is normal. In the left gaze, right eye adduction is slightly restricted. Up gaze is slightly restricted. Down gaze is almost okay. So ptosis is definite, ptosis is there. Now I'm asking the patient to put the ice pack. This is an ice pack wrapped in a gauze piece for 2 minutes. After 2 minutes, we remove the ice pack. In the meantime, ocular manifestations are the most frequent presenting complaints in myasthenia gravis. Approximately 40% of patients with presents with diplopia, and approximately 40% initially manifest as unilateral or bilateral ptosis. This test is as diagnostic as adrophonium test in diagnosing myasthenia gravis with ptosis. The improvement in ptosis is due to improved conduction through myoneural junction. It slows the antibodies against acetylcholine receptors. Ultimately, their action is increased. The improvement of myasthenia gravis with cooling probably occurs by lesser acetylcholine esterases activity in temperature below 28 degrees centigrade, providing increased amount of acetylcholine molecules in the synaptic cleft. Sensitivity in ocular myasthenia with ptosis associated with or without generalized symptom is highly varying from 80% to 100%. Specificity of the ice pack test is very high, considering that it is not positive in other diseases that can simulate myasthenia gravis such as oculomotor nerve palsy, oculopharyngeal musculodystrophy and other mitochondrial myopathies. So this is an important test which can rule out other imaging because this is a diagnostic test. Ptosis improves after 2 minutes. These mitochondrial myopathies can be ruled out. So patient can be saved from unnecessary imaging. Now you can see that still the ice pack is there for 2 minutes. And when the patient will remove, you will see definitely that the ptosis is improved. So this is an important test when a patient comes to you with bilateral ptosis. So you can rule out other entities. Now you can see that ptosis has improved. You can very well see that left eye ptosis has improved. So I have demonstrated this test.